It's time to start the KERCast, brought to you by the Knowledge and Evaluation Research Unit at Mayo Clinic. I am Victor Montori, your host for this last KERCast of this first season. And it is an amazing opportunity that we have to finish the KERCast with Professor Carl May. There is no way of doing justice to Carl in an introduction that would not take all the time of the KERCast. And so Carl and I have a wonderful collaborative relationship in our research. And so I've been thinking about how best to introduce Carl to all of you. And first of all, he's a sociologist. In what matters to our conversation, he's a sociologist that has focused on on a couple of areas that matter tremendously. One is the normalization of innovations in healthcare. And the second one is the theory of burden of treatment. He is at the London School of Hygiene in London, that does the name, but because we're in full pandemic mode, we are reaching him at home. He's one of those few people who have felt at home during the pandemic, and it is lovely, Carl, to have you. Welcome to the KERCast.
Thank you so much, Victor. It is lovely to be here, or to be there.
Yes, and to be together.
Yeah.
Carl I should have also said that you're a survivor of the Icelandic volcano disaster that had one upside that we know about, which is the opportunity to have trapped you in Rochester, Minnesota, surrounded by our colleagues of the care unit for a much longer than planned period. But that changed our lives, didn't it?
Well, it changed all of our lives. Yeah, no, that was actually a much better time than the description Icelandic volcano disaster might have suggested. No, that was really, it was just really good fun. And the thing that I always remember is just the warmth of the welcome from people who were saddled with me for yet another week and yet another week, and who didn't seem to tire of being friendly and polite to me.
You make it easy. You make it easy, Carl. So the first question I always ask in these things is, how did you become Carl May?
Well, I became Carl May through a series of entirely unpredictable events. So I left school at 16, and I worked as a hospital porter and as a hospital cook. And then I was a filing clerk for quite a long time in the Ministry of Agriculture in London. And one day I got the opportunity to go to college, and that coincided with my being asked to spend 3 weeks at the government file storage facility at Hayes, trying to find a lost document in 16 miles of shelving. And so I resigned and went to college. And I discovered I kind of intended to be a lawyer. I was very interested in international relations, and I was very interested in the ways in which the ways in which governments regulate each other. Where these interests came from, I've never been quite sure, but they were there, and I thought, well, that'd be an interesting thing to do. And on my second day in college, one of the lecturers approached me and he said, Carl, he said, have you thought about not doing law? And I said, well, no, I haven't thought about not doing law. Why do you ask? He said, because I think you'd be a really good sociologist. And there you are. It turned out he was right to some degree. And I just really enjoyed what I was doing. And I think, you know, if you enjoy what you're doing, it doesn't feel like work. And so for a long time, nothing I did really ever felt as if I was working. It was really interesting. I did a PhD at Edinburgh. I did a postdoc in psychiatry in Edinburgh, and then I had a series of lecturing jobs, and then again, quite by accident, and this really was an accident, I had knocked over a pint of milk in the kitchen of the university department that I was working in, and I was scrabbling around to mop it up. And there was an old newspaper sitting on the table, and I was sort of using this to absorb a pool of milk. And in the middle of it, there was an advertisement for a full professor job at the University of Newcastle. So I applied, and despite the fact that the vice chancellor of the university, who was chairing the interview, actually fell asleep during the answer to one of my questions, there were 28 people on the interview board. There was no oxygen in the room, and he did drift off. But I was very surprised, and I got this appointment, and so I think that was 9 years after I graduated PhD, and I was a full professor. I was an inaugural professor in a faculty that had never had a professor of medical sociology before, and I just loved it. And I have been equally fortunate to have wonderful friends to collaborate with. I'm sort of in a world where nothing is planned. There are some things you still have to work hard at, and one of those, I think, is maintaining and sustaining those sorts of collaborative relationships, and also at the same time managing them as friendships and making them into something more than the sum of their parts. Because I do know people who behave entirely instrumentally at work, but it's always struck me that they live very unsatisfying lives.
Unsatisfying work lives or unsatisfying lives total?
Well, I can't speak to their lives beyond work, but certainly I can't imagine that if that's how they behave with their colleagues, I can't think that that's how they would not behave with other people in their lives. I can't imagine.
So you are the product, yes, of chance. Sounds like you're the product of a visionary mentor who saw through that you could illuminate or confuse things as a lawyer, or you can illuminate or confuse things as a sociologist, and decided that your path was that of sociology, and you went along with it. And then it sounds like your luck was also helped by paying attention to what you were mopping the floor with, which was a professorship offered. There's a metaphor there about, crying on spilled milk and then mopping the floor with a professorship, and then people falling asleep, and next thing you know, you're a full professor. I mean, that's there's something there.
Yeah. There's an awful lot of hard work underneath that, of course.
Well, that's the thing, isn't it?
That's
Yes.
the thing, isn't it? But
Yeah.
that's why I say, if you love something, it doesn't always feel as if it's work.
Yeah.
I'm just going to close the blind because
that's all right. That's all right. The one of the things about these things that you have to work hard, you said, in addition to the scholarly work itself, the instrumental thing that you've mentioned is that you said you have to work hard at relationships and friendship. And That strikes me as one of the upsides of science, right? Is the notion that you do this, you get to show up to work and work with people that you like, work with people that get you, get what you're trying to do, that resonate with you, that build on what you're offering, that take the gift that you're offering and give you other gifts back, and you are bigger, better, faster, smarter, clearer because of the company you keep, and the same, they can say the same about, there's, that is not the picture that many people have of scientists, and certainly social scientists. You know, one looks at some, in some disciplines of social science, and one sees these papers with a single author, right? And you go, you know, is this, is, what is this, you know, is this, because I agree with you that the fun part about science seems to be the fact that you are, you have, you know, these incredible relationships.
Yeah, I think, I think, I mean, I certainly have my share of single author papers. I think I probably got 10 or 15 of them. And I think over time, it's very easy to write a single author paper when you're early in your career and you've just done a PhD. I think
Mm.
over time, and as one becomes more senior, then one's always working in big and quite intellectually diverse teams. And I don't hold with the idea that uh, that you can just suddenly decide to hijack all of those thoughts and work, um, and say that they're your own. I know it does happen. I know people do it, um, uh, but I think um, I think that denies the reality of the work that we do. You
Mm.
know, it denies the reality. I mean, I've got a couple of papers now with patients as co-authors, and uh, uh, that kind of denies that, that sort of accepts and acknowledges the reality of the complex web of social relations that we're involved in all the time.
When you, I was just going to ask you, when you when you look at your, when I look at your career, the one of the things that one sees is this uh, movement towards the production of theory. Um, Many of us have had to write grants and write proposals and hold people accountable for to what extent their activities, their choices of experiments and measures are theory informed or theory driven. But few of us have stopped to think about where, you know, what's the value of the series? Where do theories come from? How did you arrive, for instance, at normalization process theory, which has been a major contribution to healthcare and to our career? You're laughing, but I'm being completely serious. I mean, for probably the you know, one of the few times during this conversation, but you know, it's a, that's a phenomenal contribution, Carl. So how does one arrive at that?
um, uh, well, I think the answer is it's complicated, but the the Robert Merton, who was, you know, the sort of doyen of American sociologists for about 1,000 years, he had this in one of his books. He's got a great footnote where he talks about theories springing fully formed from the minds of men, and that is more or less, unless you're Richard Feynman and you're sitting in the canteen at Cornell watching people spinning plates, and suddenly the theory of quantum electrodynamics arrives in your head. That's actually not how theories arrive. So normalization process theory came out of about, I would guess, every study that I did and every PhD that I supervised over a period of about 10 years. And I walked away from these different studies looking at different areas of chronic disease management in primary care, genetic counselling in hospitals, the development and evaluation of telemedicine systems. So one of the great advantages of most of the jobs that I've had is that I was the senior sociologist in a whole faculty. And so sociology was, and most of the time, was the only sociologist in a department. So sociology was what I said it was. And that gave me the opportunity to do a huge, and this is, I praise God that I worked in medicine and didn't go in other directions, because I've had the opportunity to do a huge variety of work in many different contexts without anybody ever saying, oh, well, you're a specialist. So I've been able to be a generalist sociologist who is interested in medicine and who then became interested in doctor-patient and nurse-patient interaction, and who then became interested in how different kinds of health technologies shape clinical practice. So that's the background to my whole career, and I was struggling. I had a project with some good friends, people that I think you have met, Tracy Finch and Francis Mayer and others, where we were trying to understand how and why the National Health Service in Britain found it so difficult to adopt telemedicine systems. And I was interviewing a junior doctor then, now a very senior emergency department, Professor of Emergency Medicine in the UK. And after the interview was finished, we were having a chat and a cup of coffee and sort of just talking about the state of the health service, which is a sort of perpetual conversation, isn't it? And he said, you know, Carl, he said, the thing about telemedicine is it doesn't work. The name tells you that it doesn't work. He said, because if it worked, it wouldn't be called telemedicine. It would just be called medicine. And in that moment, that I suddenly, my head went back to an undergraduate sociology course about Peter Berger and Thomas Luckman's book, The Social Construction of Reality. And I realized, of course, that the essence of adoption and implementation is that the thing that is being adopted and implemented disappears from view. That actually it just becomes part of the normal routine of action, in much the same way that I think almost no clinician now thinks twice about having a stethoscope. I'm sure there are clinicians now that want powerful nuclear stethoscopes that cost millions of dollars and that require an enormous staff. But you know, the old-fashioned stethoscope has been, you know, that's been going on for two centuries. Everybody knows how to use it, and nobody thinks twice about it. And so that's really where the kind of inspiration for normalization process theory came from, that one moment. But it would have been impossible for it to come from that one moment if I hadn't been involved in all of those other studies, and if I hadn't read Berger and Luckman's treatise on the social construction of reality. So there's a sense in which fortune favors the prepared mind. You know, I say that, you know, nothing ever happens by accident, really. You know, all of our accidents and serendipities are only visible to us if we can see their implications.
Well, there's two other things, Carl. One is that this conversation, this insight occurred in a conversation after you had finished the interview. So the planned work was over, right?
Yeah.
And so if you had been of the kind that was very disciplined, you would have finished, let this person go, and off you go, and you would have
Yeah.
missed that moment, right? So this goes back to your interesting cultivating relationships with people that probably led to
Yeah.
that coffee and led to that opportunity.
I was
Uh,
fascinated by this man. He had so much interesting to say about his work and the life, and about the sometimes very fleeting interactions he had with people in the ER. But the other thing that I must say is that um, I am not good at everything, and I am not a great interviewer. I'm actually not a great field researcher in and many of my colleagues will smile and nod at this news. I'm quite good at interpreting data, qualitative data. I'm not at all good at actually collecting it. Um, I, we all have different strengths, and quite frankly, I find a lot of interviewing rather boring. Um, and it doesn't suit me temperamentally, and it's not something that I'm particularly skilled. I think partly because as an interview progresses, I'm sort of building a sort of low level theory of what's going on. And then I want to test it rather than collect data. Because for me, theory is nothing more than explanation. That's all we're doing. When we make theories, we're creating explanations. Or we're trying to build a better explanation for something.
what I in preparation for this interview, I told you that one of the cringe moments of our interactions, at least to me, came in a delicious dinner that you and I had, well, with our much better halves, right the night before Brexit, the vote, and we were enjoying incredible food and great company. And I said this thing, which of course was extremely, you can use any adjective you want, I'll take them all. And I said, girl, why are you spending all this time doing this theory stuff? I mean, what's the value of it? And yet here we are finding the theoretical contributions you've made having incredible practical application in the work that we do. Um, did you expect when you went into theory that you will have the impact that you've had?
I had literally no idea. If I had known how this was going to turn out, I would have been a lot more careful about how I did it. Um, uh, um, uh, I had literally no idea. I I I wrote the first NPT paper, which is sort of 2006. I wrote that for a seminar. I didn't sort of intend it to go any further than a sort of expert seminar that was funded by the Arthritis Research Campaign about changing clinical practice. But the reception that I got was so enthusiastic that I sort of wrote it up and as a paper, and then I got asked to give it as a plenary at a, a big academic primary care conference in Europe, and I did that, and then that work it obviously filled a gap at that moment. It filled a gap. Um, um, and I think it was attractive to people because it was based. It was not at all philosophical. It was
Mm-hmm.
grounded in empirical research, often done independently of the theory building process. Um, uh, I I didn't have to push too hard at the door to open it with people who were really looking, there was a real need then. It's different now because there are about 8 million theories of implementation. But then there weren't. So people were looking for something that would take them away from diffusion of innovations theory, which was not helping them, or away from the theory of the theory of reasoned action. You know, Fishbein and Asian's work about intentions and behavioural norms, and something that was a bit practical. So what in a sense we did was to describe practice, but then to take it up a couple of notches and say that these were the explanations for this stuff.
Yeah, so orienting people to the space and
Yeah,
providing explanation for success and
yeah,
failure.
yeah. So and that seems to have worked, and it so we described, and then as you know, I had later on opportunities to go to the Mayo Clinic. I had at the same time opportunities to go to Australia into Jane Gunn's department in Melbourne, which was no less friendly or congenial than the Mayo Clinic, but was much closer to some pretty good vineyards. And so I had the opportunity to work with tremendous people around the world very quickly who saw an opportunity with NPT, and then a series of grants, and some of which were very small, to continue to develop it. And then my partner in crime, Tracy Finch, and Tim Rapley, who was a research fellow in my group in Newcastle, they're both now full professors at in Northumbria University at Newcastle. They put together a great bid for money to develop a set of quantitative instruments to measure these constructs. I'm never going to be a big statistical researcher because I'm very profoundly affected by number recognition dyslexia. So in fact, I look at numbers and it's just like looking at, I don't know what, grey. It's all grey.
Well, I'm glad that you're into words, because that is, that helped. But one of the things that was attracted to me about NPT was the fact that it focused on the work that people did, not what was in their minds or what we thought was in their minds or the explanations they gave after the fact, but what was observable and what was it. The other thing that resonated with me about it is that he talked about collaboration, and just like you describe research as a very collaborative activity with friends and so forth, the theory that you've developed also recognizes that same phenomenon of collaboration among people as the key machine of implementation and normalization. And that also resonated with us because we've been working on shared decision making and other things, and in those are paradigms where we go from the self-management idea, the motivation idea of patients, to the notion that care is a collaborative activity in which patients and clinicians are working together to make it work, to make care fit, which of course is the theme of this conversation. So that was very attractive to me. Do you think that your appreciation for this idea of people working together is a reflection of, it came from your recognition that you were doing that as part of your research, or is that a worldview that you bring with you and that allow you to see that and put it in your theory, or that it really emerged from the empirical work?
I think these things come from multiple sources. So I had actually, as a junior civil servant, been involved in implementing things. Nothing of value or importance, but at the same time, I sort of had a sense of what you need to do to get something done. That I remembered that sometime after I began the project, I think that this comes from having a sociological worldview, because that
Mm,
says humans are social creatures.
mm,
The whole business of being human is about interacting with others, and if we are denied the opportunity to interact with others, terrible things happen to us. So, if you go to the Supermax in Marion and look at prisoners who are kept in a concrete box for 40 years, um, uh, they're in a pretty terrible state,
mm.
because they're completely denied opportunities for sociability. But in history, we see um, very few big things that happen because of individual behavior change. We see lots of things that happen because of collective action and collaborative work.
Yeah, yeah, but Carla, the mythology of discovery, the mythology of advancement is often told as the story or the history of usually a man, of that like you said, saw it and made it happen on the force of
Yeah,
his will, right? And there's this strong mythology of the individual making a difference.
I think that's true, and I think that's because um, uh, uh, those sorts of narratives are hugely attractive, and also because they're quite easy to tell. Well, we have some great evidence to the opposite. Um, um, if you read the transcripts of JFK in the Oval Office during the Cuban Missile Crisis, it's absolutely clear that he's making decisions. But what he has in front of him are an enormous team of people who are talking to him all the time. So this is collaborative work and collective action at its best. I a book that I go back to again and again and again are the diaries of Lord Allenbrook, who was the field marshal in charge of the British Army during the Second World War. Uh, um, uh, Almost nothing in these diaries is about him. It's all about him and other people. It's about his relationships with Winston Churchill or Eisenhower or any of these people. It's about the creation of a network of actors organized around very different versions of a common cause.
Mm,
Um, uh, 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 um, and we, in medical research and in health services research of different kinds, we neglect these wider kind of opportunities to explore and understand behavior to our peril, because we say, oh, these things only happen in medicine, but you only
mm.
have to pick up a history book to see that they happen everywhere all the time.
So when one looks at your career, then do you recognize a principle or a set of values that has been pushing you forward?
Yeah, I do. um, I think I feel very strongly that behavior matters, and how we behave towards each other matters. And um, uh, I've so I have tried to um, behave well towards others, but also towards my work and towards the people that I work for. I think I love what I do. I care about it very much. I care about the people that I work with very much. I'm very fortunate that I have some fabulous, talented PhD students, and I have had many of those over quite a long time now, and some of them have become incredibly powerful researchers in their own right, um, with big research teams. I love mentoring. I love all of that stuff. Um, uh, but so my values are around trying to do the right thing. That's not always an easy or painless process. You know that as well as I do. Um, uh, but trying to do the right thing in the context of collegiality and congeniality. So I've also obviously had senior management roles in different bits of different universities, and so I have encountered some of those difficult moments. But so I try to just do the right thing, but as I see it, not as anybody else sees it, as I see it.
But this is so behavior towards you said behavior matters. So this was behaviors towards the work, towards others, towards yourself.
Yeah, yeah.
Hmm.
I, I I had the great, I don't know whether it was the good fortune or the great misfortune to be assigned a leadership coach at one point in my trajectory, when I think it was thought by my employer that I might one day want um, to be in charge of something important. And it turned out that she was an exceptionally astute and interesting woman. And
A coach.
yeah, and she sort of encouraged me to think a lot more about behavior and what was good and what was bad, and to be very clear about what I would tolerate from others,
Hmm.
what was acceptable or unacceptable. And I found those conversations extremely useful at a time when, like a lot of people in healthcare, in higher education, in any kind of organisation, I was confronted with people who were behaving in a very difficult and challenging way, and I was being pulled in several different directions, and that sort of helped me get back on track, really, in terms of what personal integrity means to me
Mm-hmm.
at work. I think it's very easy to possess personal integrity when the mortgages of others don't depend on you.
Mm.
I think I think it becomes more difficult the more distributed your responsibilities are. There's always an easy way out of lots of problems. So I'm not going to suggest that I've suffered immeasurably for my art, because obviously I haven't, but I have tried to behave well towards my data, and behave well towards my colleagues, and behave well towards myself in those contexts.
Yeah, well, it seems like that's is a good way of. In fact, it resonates quite strongly with our in the care unit. We have this set of values that we make explicit as part of our culture, which is that we're patient centered, that we try to act in high integrity ways, and we try to act with generosity. And I suspect that coincidence of values is one of the things that made it easy for us to work together, Carl. One question that has come through, I think, connects this conversation we're having about behaviors with the conversation that we had earlier about normalization. And one of the things that has normalized in some of our institutions in healthcare and is come to the fore, I think, with significant strength recently, and it's unfortunately it's only recently with this significant strength. It's the issue of the extent to which we have organizations that are cruel, oppressive, exclusive of groups in the United States, I think, and in the UK to some extent, in Europe to another extent. Those groups are sometimes defined by racial, ethnic characteristics, by migratory status, by gender. Is there a way of applying normalization process theory to the denormalization of those oppressive structures?
I hope so. I hope there is, because what I think NPT does is it provides a way of helping us think about how to achieve particular kinds of objectives. I'd say that an implementation process is defined by the translation of strategic intentions into everyday practices. So if our strategic intention is to replace one set of practices or one set of categorizations with another, then implementation science as a field ought to help us to understand and to create route maps and waypoints that we can travel down. But I think the more important component of some of what we're talking about is the sort of moral logic that underpins whole systems, where I've been having a debate with a friend in family practice in the UK, where we've been talking about how the shift to providing medical care by telephone and video conferencing during the time of COVID has changed relations between doctors and patients. And I think what this has brought into sharp relief in some contexts is a tendency that was already well underway to hollow out the bonds of moral obligation between doctors and their patients, or between states and citizens, and to reduce all of this to an entirely transactional state of being. Mm-hmm. Now, that's what's happened in many other sectors of the economy.
Yes.
And you know, our friendly bookshop owner has vanished. You know, the lovely bookshop over the road from the Marriott Hotel in Rochester, the Borders, I think it was, that I really used to enjoy going into, and I got a great pile of books every time I went to, or every time I came to Rochester. Where you could actually speak to somebody who was knowledgeable about books, has vanished, and it's been replaced by Jeff Bezos, who probably doesn't want to talk to me about what the best sociology book on the market at the moment is. Although perhaps he does, I don't know.
Well, we have this. This is why we revolt. Carl, is a loss of that both the solidarity at the level of the society as a whole, and community, and partnership, and friendship, and collaboration. So I see that.
Yeah, that is the sort of undermining of some of those features of the societies that we live in, I think, has been quite interesting, and their replacement by other forms of attachment, I think, is equally interesting. For a long time in the United Kingdom, I would have said it was very bad manners to talk about politics. By and large, unless you were with people who were in the middle of it. I would never, for example, wander around to my parents' neighbours and say, "Well, how do you feel about the Conservative Party?" or whatever. It would have just. But what Brexit did, and you talked about Brexit, which did a grim night in many respects, leavened only by that lovely conversation, and I recall an excellent bottle of claret. But that created a set of political attachments that weren't about political parties. In much the same way, I think we see happening in the United States, a set of political attachments that aren't really about being in a political party, but are about objecting to the way in which politics and economy are organized in different ways. Although the difference between the United Kingdom the United States, as far as I can see, is that most of the people who are objecting in the United States are carrying automatic weapons and wearing funny hats, whereas
both countries are trying to challenge their first names on a daily basis, all but united. Let me go back to theory because this series is about care that fits. And one of another phenomenal contribution that you've made, in which we have had a bit of a contribution ourselves in the care unit, has been this theory of patient work and patient burden and treatment burden. How did that come about?
it's a natural consequence of looking at the normalization of clinical innovations. If we're going to look at the normalization or implementation of different kinds of clinical interventions, then to fail to look at their impact on the people who they are intended to benefit, I think, is negligent. Actually, I think everybody wants to believe that whatever new machine or decision-making tool or whatever that we introduce actually really does improve the lives of its users. But very often it's just more work that is difficult to fit in. And I had, in 2011, I had a period of very acute and nearly fatal illness that meant that I was not well for a couple of years. And I really began to think about all of the work that I was having to do for different doctors, and the immense amount of work that my wife had to do to sort of keep me tracking back and forth to hospital and to different clinics and things like this, and plugging me into whatever tube people felt like plugging me into that day. And I began to track this. And at the same time, my mother-in-law was sort of entering her decline. And one day, as a sort of experiment, as a thought experiment, Christine and I, my wife and I, plotted out a map of all of the people who were actually contributing to keeping her out of an assisted living facility, and sort of mapped what they were doing. And it came to, there were about 30 people involved. And I thought, what an enormous amount of work is going on here. Actually, much, much more work than would ever have happened if she had gone into an assisted living facility where, she would have been looked after a bit and, and I sort of began to do that for myself as well. And we kept time diary of my mother's hospitalizations, things like this. And I just suddenly became aware of the enormous workload of ordinary healthcare, not anything that's innovation, but just if you are involved as a patient or a caregiver in the management, the self-care of chronic multi-morbid disease, the huge body of work and time that involves, and the way in which that stretches out across networks. And so we wrote this, and you were a co-author, and so were members of your group, Casey and Nathan Shippey and David Eaton and people like that. We wrote a series of papers, the cumulative complexity model, the burden of treatment theory model, Casey's bruise model, that sort of brought up to date the sociological interest that had been very long standing in what people need to do, the work that had come out of Anselm Strauss's research group in San Francisco, which I go back to again and again now for all kinds of reasons. But and his PhD students, Juliet Corbin and Kathy Chalmers, who died this last year, Adele Clark, those kinds of people who were doing these fabulous studies of patient life and patient work. And I think what we did was to ask ourselves not about what's the work that you have to do to be a patient, but what is the delegated work that comes from a healthcare system. And this is, I think, where your interests in sort of industrialized medicine and mine in wireless patients coincides, because it is about this, that there has been a qualitative change in the nature of patienthood over the past 3 decades, where now it's not simply just about reformulating one's identity in relation to a physical, physically
Getting a
embodied
new
thing.
passport for the country of the sick, so
It's
to
actually
speak.
about becoming an unpaid member of the healthcare workforce. Um, you know, you quite often see this. The patient is part of the team. Well, the patient is only the part of the team to the extent that they conform to what the team wants them to do. And the patient is only part of the team to the extent which they're able to summon the cognitive resources, the material equipment, the financial wherewithal, and actually the social networks that are needed to support that activity. Um, uh, uh, and that I find, I feel very strongly that that's something that needs to be thought about. That innovations are great for healthcare systems, but actually they're not always great for the people who are intended to benefit from them. And so there is this, the Janus-faced nature of healthcare innovations. On the one hand, you know, we're all benefiting from things that will keep us alive longer and polish our pancreases and all of the other stuff. But at the same time, we're having to give up more and more of our cognitive and informational and material capacity to actually work with that.
So it's again, there's a unity to this, which is that the burden of treatment theory, one of the contributions I think it makes is it brings up a lot of attention to the fact that the success of the implementation of treatment plans not only involves the mobilization of personal resources, but the mobilization of people around you that can collaborate and work with you to try to make that work, right? I mean, once again, the notion of self-management kind of challenged by the notion that, in fact, it takes a village to be a good patient.
Well, actually, it takes a corporation, I think, that you see, I think, informal work groups with a clear division of labour, a clear allocation or self-allocation of resources, and sometimes those work groups bridge informal networks of friends and acquaintances. They are sort of Venn diagrammed into different bits of the healthcare system. So throughout throughout my process of illness that I was talking about just now, without a doubt, the most significant worker was my consultant secretary, who was the font of all knowledge, who rearranged appointments, who made it possible to do one thing or the other, because I was desperate to not stop working. And so I needed the system to make some concessions to me about when I could see doctors and things like this. And I think, you know, being a professor in a medical faculty helps you with that, but not as much as you'd think.
Well, this has been a wonderful conversation, Carl, and we're coming to the end. And I normally ask, what are the next steps? But I'm going to make an exception here because there's a question that has come through that relates to advice that you'll give to somebody starting a PhD in implementation science. And I was just wondering, as we talk about collaborative groups and how success comes through collaboration and working together, that we still judge scientists and students individually for their individual accomplishments. People don't do dissertations as a collaborative endeavor, and we don't evaluate them collaborative, in their ability to actually bring a team together to execute things. We tend to evaluate the individual, test the individual. So can you bring this together? What advice would you give to somebody that's starting, and does it?
The sociological critique is we value people who conform to a set of norms and conventions, but we think that valuable work is what sits outside of those. So there's a difference between what we value and what we think is valuable. My advice to anybody beginning a PhD in any topic is, under no circumstances, work on a PhD that doesn't interest you. There is no good reason to spend 5 years of your life dragging away at a topic that you don't enjoy. If you don't enjoy that sort of work, don't do it. Pick a question that is fundamental. Never do a PhD about evaluating something. Who cares whether it works or not? The really important question is why. So fundamental questions are much more important than pragmatic ones. Even when the money is for a pragmatic thing, find a fundamental question to ask. I was very fortunate that I could absolutely choose the topic of my own PhD. Nobody tried to control it. Nobody could be bothered actually to try and control it, as far as I could see. But those were very different times, I was able to read and study what I wanted. So I say, if you're going to do a PhD in implementation science, find in it what you believe you are going to love, because otherwise it's a hard journey.
And how do you deal with fear? Because it seems like, if you pursue what you love, sometimes you're going to find yourself in pretty dark places where people may not have been, where others may not understand why you're doing it, and you'll be completely consumed by imposter syndrome and so forth. So how do you handle that?
Well, there are two ways that you can do that. There's some people become entirely narcissistic, which is a very successful strategy, I have to say, in those circumstances. But we all have to. The really important thing to know about any research career: all research careers end in failure, all of them, because at the end of the day, the problems are still there to be solved. We can only make an incremental contribution to getting there. So imposter syndrome is often founded on a view that we should all in some way be outstanding and perfect examples of the research enterprise. None of us can be. Failure is the single most important thing that we can do, because that tells us what we need to learn, how we need to grow. I'm not suggesting that people should fail their PhDs, but I am suggesting that that people, the imposter syndrome is something that is foisted upon us. None of us need to be imposters. We do need to have a sense of proportion, and we do need to care less about what some people think of us.
Well, Carl, the answer to my question as to why the heck work on theory, I think you've explained this as the about the value of fundamentally asking questions of why,
Yeah.
and you said in the preparation meeting that we had something that stuck with me, which is that the most practical work that you've done is your work on theory.
Well, it is. I mean, without a doubt. I've provided, and other people, um, uh, very close collaborators who have worked with me on those projects, Tracy and Tim and you and Jane Gunn and Francis Mayer, many others, um, have, um, have made all of that possible. I feel that you know, in lots of ways, I've been blessed. You know, we all suffer from imposter syndrome. There's nobody who's never been anxious about themselves. And believe you me, there are few things that call upon more hubris down upon an author than calling a paper towards a general theory of anything. Um, that's the point where you discover the true meaning of imposter syndrome.
Carl, I can't imagine a better way of finishing the first season of the KERCast than this conversation with you. It's been a lovely, lovely, lovely moment. And I want to thank you very much for your time. And thanks everyone for joining us at the KERCast. And I hope we'll see you on season 2.
Yeah, thanks very much for having me. I've enjoyed it too. It's always such a pleasure. Always a pleasure to talk with you. And so I don't actually know who's out there, but hello, everybody. And I hope I haven't bored you. Um, so
The
there you
only
go.
question that has been left unanswered, Carl, is why there is a T-Rex behind you.
Well, that's Terry, and he is he is a monster. We should all have a monster, you know. I think it's very important to keep having toys.
I think this is the best way to finish this conversation. Take care,
Okay,
Carl. Thanks,
great to
everyone.
see you. Bye
See you
bye.
next season. Bye-bye.